So I was asked to talk a little bit about pain management in rural areas, but I mean, she did say I was an engineer, so I've kind of got to break this down and tell you a little bit of a story. And I like to tell stories in data, okay? So the first couple of folks that y'all listen to probably don't like to tell stories in data because that's not the side of the brain that works for them, but that's what I think is fun, so that's what we're going to talk about. Because I'm also a third-generation teacher, and, you know, we like to talk. So anyway, if you look at this slide, it will show you the change in rural and urban population from 1910 to 2010. And if you will notice on that, 1 out of every 5 citizens used to live in rural areas. And that covers, the rural areas in the United States cover more than 97% of the land area in the U.S. But if you look here, most of the, I mean, while the rural population has stayed the same, as populations have grown across the U.S., it's kind of left rural America behind. It's really taken a toll on rural areas. Health outcomes, healthcare access, drug overdoses, all kinds of issues, socioeconomic disadvantages, which lead to a lot of these things. And so that's what it's looked like over time. Life expectancy in rural communities, especially for men, has really gone down. Now you say, well, that's just 2 years. You know, that's not really that much. Well, it really is that much, because if you're a white female in a rural area, you're going to live 10 times more than a black male in a rural area. 10 years, that's a decade. Okay, so this is an average of all people in rural areas, but if you look at it, you know, kind of break it down, which I didn't do because I didn't want to bore y'all to death, that's really pretty serious. Here's what mortality has looked like before we get into things like suicide and stuff. Just the mortality, again, back in just as late as 1968, between urban and rural areas was basically the same. And it trotted along like that until the 1980s. And you know, back in the day, people in urban areas probably really died at higher rates because they were close together. Infectious diseases, dirt, you know, all those kinds of things caused people to die. But you know, with vaccinations, public health advancements and stuff, all that kind of stayed the same. But now all of a sudden, rural America's really being left behind. It leaves a person to wonder why. We could kind of explain why people were dying in the urban areas, you know, filth and open sewers and all sorts of stuff. But now that things are, you know, modern medicine has kind of taken vaccinations and things away. So why are people in rural areas dying, and what are they dying of? So if you look at this fun slide, mortality rocked along from 1968 to 1985. In rural and urban areas, about 1.5% a year, our life expectancy went up as Americans. Okay, it went down. We were getting better. We were going to live longer. All of a sudden, about the mid-'80s, the urban areas still were going down. Life expectancy was still going down at about 1%, which you should sort of expect. It can't get better 1.5% forever and ever. You know, you'll be living to be, you know, 150 or something. But look at the rural areas. It really fell off. It really fell off a little more than 0.5% a year. And so you know, again, why is that? And then when you break it down a little further, and this is really kind of scary, if you look at the United States, all of the causes of mortality by race and ethnicity from 1999 to 2015, it's caused by one thing. Everybody seems to be going down on this slide. Everybody seems to be getting kind of better, or at least staying the same, except for one group. And it's an interesting group. It's middle-aged white males. And you know, y'all were talking earlier about who were most of the farmers, or at least were, back a decade ago, and still to a certain degree are today in rural America. Middle-aged white males. And so they make up as a single unit the difference between the mortality that's different between urban and rural areas. So I find that to be interesting. As much poverty and as many health disparities as we have, especially in the Mississippi Delta. There's a huge ethnic disparity. There are all sorts of issues, but the mortality has increased for a totally different subset than a person would just think by reading the newspaper, which is interesting. And there's an alarming number of deaths due to external causes for these middle life people. And the thing that's causing these are deaths of despair. Do y'all know what that means other than the people that are trained? But a death of despair is somebody that dies of drug or alcohol abuse or suicide, things like that. Those are deaths of despair, and those are what are really increasing among this subset of people. And again, I'm not the person that says why. Y'all heard from those people. They know a lot more about it than I do. I can just tell you what's happening and what we're trying to do about it. So this next slide, oh, I'm sorry, this is the slide that shows the deaths of despair. I didn't flip my death of despair. That's really bad. And this particular slide, I took it a little bit different. This takes into effect the whole world. Well, the whole world of countries that are pretty much like us. You know, they're countries that are they're industrialized, Canada, the United Kingdom, you know, places like that. And look at where our rural men are among everybody. It just scares me to look at that. Midlife deaths of despair in the United States. I like to do maps like this because I think you know, pictures show a lot of information. Look at all those rural areas, and you can tell because y'all are from rural America. That's what it looked like in 2000. Look what it looks like in 2014, and those are just the deaths of despair in this country and the changes of where they've come from. So it's a crisis in rural America, and you don't have to have a lot of statistics. You can just kind of look at that picture and see it's not just happening in one place, it's happening everywhere. Now, what has interested me is the opioid-related deaths. If you just take them, and the green is, I don't think it's showing up on that screen right there, but the green is rural, okay? And the kind of light gray is urban. And so you look at that and you say, well, other than in the Northeast, which I really, to define Northeast rural is kind of strange to me. I mean, Vermont, New Hampshire and stuff, I mean, but they're really a rock's throw from New York City. So, you know, we got 8,000 square miles that we're dealing with in Mississippi. That's a lot different to me than the Northeast. They don't have that far to travel, in my opinion. But anyway, it looks like it's not really that bad, but it's in comparison to the population, so it really, really is. So this slide may show you a little bit more between 1999 and 2016. That's the increase in just opioid mortality in the United States. And look at those numbers from rural America. Now, I just told y'all that not a lot of us live in rural America anymore. And so for that many people to be dying in comparison to how many people actually live there, it's a crisis. I mean, it's a big crisis. So okay, I'm stopped showing y'all some slides for a little bit of time, and let's talk a little bit about what's wrong. The unemployment rates are awfully high in rural areas, as you know. I do have a lot of people that work for Delta Health Alliance, a lot of farm wives that work for Delta Health Alliance because they need insurance. A lot of them. Because they need insurance. So there's a lot of that they could be helping on the farm, except for the fact that they need insurance, and so they're going to do something else to get the health insurance for their families. We talked about the high rates of maternal and infant mortality. I think the Mississippi Delta, unfortunately, leads the country in infant mortality. We've done a lot to improve that in the last little bit. Especially maternal mortality, but infant mortality is extremely high in rural areas. And of course, if you've got 12-year-olds and 13-year-olds having babies, that also, produces that as well. You've already heard about the divorce rate. The divorce rate's increasing, you know, out of proportion to metropolitan areas. The severity and incidence and prevalence of malnutrition is extremely high in rural areas. You know, in rural areas, we grow food, right? I mean, we grow crops, and we should, you know, there are people that milk cows and grow cattle, and I mean, we feed the world out of the rural areas of the United States of America, and we have malnutrition. That has really, that's bugged me. I mean, and I can go into later, if we have time, about sort of what we've done about that, but it's a real problem. Many rural underground water sources are contaminated for a wide variety of reasons, and there's just not the infrastructure. You've heard about the infrastructure for Wi-Fi and all of that, which I truly believe is the case. Rural areas don't have Wi-Fi, they don't have access to things, but they don't even have water. If you flip it back to the 1910, there was contaminated water in the urban areas for a lot of different reasons before people figured out actually how to, you know, provide humans with clean water. Okay, that was back in the day. Now we know how to do it, but for rural America, the drinking water doesn't even meet federal bacterial standards in rural America because nothing's happened to it since for all those years, and it's been contaminated. And then the housing rate. I mean, we've got people in the Delta. Substandard housing is not a strong enough word. People in churches and everything around the Memphis metropolitan area and the Birmingham metropolitan area always want to go to Jamaica or Honduras or somewhere to go do a mission trip. And I tell these kids, I go to see these children, I say, you need to come to Delta. Come to the Delta if you want to do it. I mean, I'm sure y'all from other rural areas in Georgia and Kansas and Minnesota and other places can say, come to my area and see what this looks like. You know, you do not have to get on an airplane to see, and I you know, I would show pictures, but I just decided not to because that would just be offensive to walk and take a picture of some of these these houses and these housing situations. So when you look at that, you also look at the common injuries. I mean, people say, well, why are you talking about injuries? Well, if you want to talk about opioids, you've got to talk about why people are prescribing opioids. Now, there is a certain sect, of course, of the black market that people get on opioid use because they're just trying to get high, okay? But what I've seen, at least from my personal experience, is it's overprescribed by physicians. In the Delta, we have got a fourth the number of physicians that we need compared to the U.S. national average. We've got 1/4 the number. And these people have an average age of 63 years old, okay? So I feel sorry for them. I mean, they got more people than they can see. Most of them are on Medicaid and Medicare, so they're not making a whole lot of money out of this. And people are coming with all kinds of problems. They're coming with injuries like you see here. If you're on a farm, you're going to fall. You're going to have joint locations. You're going to have, you know, all kinds of multiskeletal problems, and so you're going to be in a lot of pain. So if you don't have the proper care and this doctor is overwhelmed, what are they going to do? They're going to try to reduce your pain. And I don't ever think anybody meant to, you know, be a Dr. Nick for Elvis. I don't think they meant to do that. I really don't. I just think they were saying, let's get rid of your pain and hope that you can get to somebody who can help fix it, but there's nobody there. Because it looks, I mean, the cotton's not growing, it's been burned off, and it's between planting seasons. That's what it looks like. And all y'all know what that looks like. You know what it looks like in all the areas that you're from. It looks like that. And so it takes a really long time to get to somebody. And who's going to work the farm? And who's going to pick up the kids from school? Because you're talking a day round trip to go see somebody. Which telemedicine takes care of a good bit of that. And we do use telemedicine, and we try to use electronic health records in a combined way so that we have that continuity of care. And I'll talk about that in a minute. But these are the numbers, kind of the minutes to receive care for routine care and urgent care in rural and urban America. And it doesn't look it doesn't look startling, I guess, if you look at a slide like that, but you've got to travel 2 to 3 times more in an urban area for routine care. But for specialty care, 8 to 9 times more. Because in the 8,000 square miles of the Mississippi Delta, we've got 2 pulmonologists, we have 0 endocrinologists, and every 3 counties has maternal child well-being so that somebody can have a baby in a safe environment. So that's a long way. Have any of y'all ever gone into labor? Would you like to drive 3 counties over to have that baby when you're in labor? I mean, you know, that's tough. So you can imagine why the infant mortality, the mom mortality and everything is so desperate and so bad. Transportation's a huge problem. But this is what's really, I think, very telling. The referral sources for substance abuse. In urban areas, it's you know, the court system, yeah, refers a few people, and then there's some self-referral. But look at the criminal justice system in rural areas. What happens, rural people aren't more criminology oriented than urban people. It's that it gets so bad because they don't have anybody to go see. There's no self or individual referral because who are they going to refer to? Who's going to help them? And so it gets so bad the criminal justice system takes over in rural areas. And that's why you have this issue, because there's nobody to cause a self-referral, there's nobody to refer to. And so it ends up getting into the criminal justice system where that sort of really got us involved. So what have we done about it? Yes, we use mental health, substance and abuse counseling via telemedicine, which you've heard all about, so I'm not going to try to repeat that. We did get a mobile health clinic, thank you, USDA, to do physical therapy as well as mental health services provided by, so we could do physical therapy, we could do occupational therapy, we could do speech therapy, we could do a lot of different therapies on here. But the cool thing about the medical unit, and we hope to get another one, is we do everything on this unit from EPSDT screenings for little children to this physical therapy to we also can do some counseling on this. So people go to the mobile health clinic and you don't know what they're going for. And as y'all know from most of you being in rural areas, everybody is in your business. Okay, I mean, you're just used to it. Okay, everybody's in your business. And because everybody's in your business, a lot of people, it's not cool to say I'm going to the psychologist or I'm going to go get counseling. It's not cool. It may be cool in urban areas now. I mean, people like in Memphis and Atlanta say, well, who's your therapist? I mean, that's like cocktail party conversation. It is not cocktail party conversation in Greenville, Mississippi, I promise. It's just not. I mean, that's just not what people, it's not cool, you know? So people don't want to go to the few mental health providers that they've got because their car is going to be seen there and people are going to be talking about them in the grocery store and at church and all that, and so they just don't go. But if we do things like this, and we do have some non-mobile clinics that we try to provide a lot of services in one group setting, and people seem to come because you don't know why they're coming, and that's really helped. It's really helped considerably. There are some policy challenges. I mean, we really like to work on health policy. You know, physicians aren't, when you've got an average age of your physician of 63, and I don't know what it is in y'all's rural areas, but that's what it is in ours, there a lot of training that needs to be done is not done for people to know what the current method is to try to give people medications to help with their withdrawal symptoms, help their addiction treatment, and plus the fact that if you were the physician and maybe the only family physician in that county, you were probably the one that prescribed it in the first place, and so you kind of don't want to admit to yourself that now you've got to help them, you know, back off of that. There's proximity to HRSA recognized opioid treatment programs, and HRSA is really good about helping rural America, but it's still a long way off. In Mississippi, we can't exchange needles, sterile needles. Now, I don't know about you know, and I know everybody likes to tell Mississippi jokes, but I mean, we're probably not the last state to say you can't do that. But I mean, it's kind of common sense, but that really causes a big problem because, you know, it's another stigma, you know, that you have to kind of go through. And then the cost and the coverage by public payers, which again is a state-to-state decision, is a big policy issue for us because you have to kind of take the stigma away from this because a lot of these people, you know, somebody's 80-year-old grandmother, I promise you that she didn't go off trying to get drugs on the black market to get high. She just didn't. She did it because of pain. She did it because nobody could take care of her, and now she can't get off of it. And on top of all that, she's got to go to choir practice on Wednesday night, and she don't want everybody talking about her. So, I mean, she's just got this myriad of problems, and what are you going to do about it? What are the potential solutions? I truly believe that coordination of care is a big deal. Everybody's got strengths, and every rural community, I think, is really different. And so to coordinate care and to figure out what that community does best to be able to coordinate the care, I think is really important. Because sometimes I read things that are coordination of care things, and it says, well, you need to have a really strong this and a really strong that, and you know, this can build up. But if you look at the community, what you really need to do is say, okay, where is our strength in this community? So who can kind of carry the ball? And then let's coordinate everybody else, and then a rising tide kind of lifts all boats. But if you try to go by a cookbook method, in rural communities, you really can't do that because everybody's got different strengths. So sometimes, you know, a local clinic might be strength. Sometimes there's care centers that might be a strength. Sometimes the court system is really strong and understanding and can help. We work a lot with our court systems. They are strong, but they're also very understanding. It's not like they're almost a referral source for us, and you know, to give people a break. Recovery support services in rural communities are a problem. Safe housing. We spend people say, what is Delta Health Alliance doing in job readiness? And I'm like, well, you know, if you start with poverty and you don't have a job, your stress is really high, you don't have health care, so you don't receive any care, and by the time you get to us, you're super sick. So if I could do anything to stop that before it starts, and if that includes job readiness, job readiness and education are a high percentage, probably 35% of what Delta Health Alliance does. And a lot of people think I'm crazy, and that's okay, but I want to stop that cycle from ever starting. And if I have to spend a lot of time in education and job readiness, that's what I'm going to do because it reduces the stress, it gets people to where they need to be, and so I don't have to see them. And so just like the man that talked earlier today that said, you know, with suicide prevention, you could either be embarrassed or you could have saved a life. Well, so maybe some of those people I'm not really going to help and they never would have shown up in my clinic, but I bet you a lot of them would have. And so that's what we're trying to do. So physical and occupational therapy, fitness training, walking groups, we've really tried to spread that around the Delta, saying, hey, you could have a yoga class in just about anywhere. I mean, we could all just move a couple tables and have us a yoga class right here. And so we've really, the elderly have really gotten into this chair exercise stuff. They really love that. And so we've tried to train the trainer. You could have chair exercise just at just about any building that you've got in a rural area, and it's easy to go teach people how to do that. I mean, the yoga thing, people think you're kind of being weird and urban, you know, a little bit. When they start off, they're like looking at you like, yoga, really? But then you do it. For a while, you just do this exercise class, and then after 5 or 6 times when they really like it and they're feeling better, then you tell them that was yoga, and they go, oh. You know, so that's the same way with Pilates. They're like, I don't know if I want to do that. You know, so really we just don't actually get out there and tell them everything at first. The same thing with acupuncture. Oh my goodness, they just freak out at acupuncture. But trying to do that kind of thing and get groups together that do that kind of easy stuff really helps the physical and occupational therapists not have to do as much of what they do, and it's an easy thing to train people to do, and it's a communal thing. You've heard a lot about how people being alone and isolated causes a lot of these problems. Doing some of this stuff helps them mentally and physically. They're also doing it together. And we've just found a tremendous, we have one class in Leland, Mississippi, which is a not very big place. I don't think it even has 3,000 people. But it's this one class, and this one nurse said, she was actually not, she was an LPN, I believe, but she says, I know how to do Zumba. I said, okay, good. We're going to have a Zumba class in Leland. There, I wish I had brought a picture, because there are little 9-year-old boys and little 80-year-old white-haired women. And they're every ethnicity that you can imagine, and they're all in there doing their form of Zumba, and they're doing it together. And it's really helped that community. It's helped that community in 1,000 ways, but it's helped that community get up and move and do things. And it's just been really wonderful. Our Zumba class got so big in Leland that we had to move it to a church hall, because doing it in the, we were first doing it in the waiting room of the clinic. We'd just pull the chairs out at night and they'd just do Zumba. And it got too big, and we had like over 50 people, which for Leland is a bunch of people. And so we had to, had to move to a church out of the clinic. So that was really, really good. Recovery support services, everything. Again, the recovery support services are the same thing that we started with before, because once you go into that recovery mode, you've still got to have the things that you needed in the beginning, the job training. You've got to have safe housing. You've got to have child care. You've got to have that support. We do a home visiting thing called Parents as Teachers. It's been extremely helpful for us for a lot of reasons. We parent like we were parented by and large. Would anybody really disagree with that? I mean, that's really the only thing you know, right, is what your parents did to you, all right? Now, that might have been wrong, okay? And you might say, okay, I'm going to do the exact opposite of what my parents did, but how you were parented affects how you parent. And a lot of these families, you have to break that cycle of really abuse, which causes a lot of injuries. It causes these problems, and it leads to this addiction problem. So the Parents as Teachers, we first started doing it to help the children and the younger, the adolescents, and people not get into this cycle. But what we realized is it helped the moms, especially because then they had a group. They all had a home visit, and they had a group, so they could, okay, well, I'll take the kids this night, and everybody else can go to community college for this class, and then you take them that night, and all that seems intuitive to us, but I don't think, at least our population wasn't really used to asking for help. They were used to rowing their own boat and very proud of it. And there's nothing wrong with that, because the work ethic is huge in rural America, but that doesn't really lend a person to really asking for a lot of help. So this is my only touchy-feely picture, and it's my last one. But it sort of shows the outcomes, the coordinated systems. And again, all of these things are needed to create an environment to help people get over the opioid abuse, to help the people from having an opioid abuse, and to do all the things that keep them from going down that slippery slope. And again, in some communities, one thing is a lot stronger than the other. Sometimes Indianola, Mississippi has the strongest business community I think we've got in the Delta. And so sometimes that business community is going to help lift those other boats. Sometimes you've got a really strong rural health clinic. Clarksdale's got a really strong rural health clinic, and that's what lifts the boats. Not that you don't have the other ones, but somebody can choose to take the lead, and I think that's a big deal. The one thing that has really, really helped is our ACE awareness campaign. Have y'all ever taken the ACE test? Who's taken it? Not many of you. Okay, a few of you. Well, go take it. Go Google it and go take it. There's 10 questions. It's really easy. People have a lot of ACEs. The average ACE in our neck of the woods is 6.
Could you please explain that for people who don't know what it is?
Okay. Adverse childhood event is what an ACE is. And the studying that's going on right now behind this is what builds resiliency in a person. How is resiliency built? How can the same thing happen to two different people and one person go off the rails and one person get through it? I mean, what's the difference in those two people? What is that? And the work behind this, we've had a guy that's kind of written a book on this named Vincent Valetti actually come to the Delta and kind of help us with it a little bit. And we're starting with the younger children and all that, but when we looked for money to help us with ACE awareness, we did not, most communities have to go take a test of their community. They have to go out and survey the community to see their average ACEs. They said, oh, you're in the Mississippi Delta, you don't have to. Just go ahead and apply. You don't even have to do the survey. And we're like, really? And they were like, no. You've got so many ACEs, it doesn't matter. And we're like, wow. But an ACE of over 4 is considered pretty catastrophic. And it's things like, have you ever witnessed a murder? Have you ever been beaten? Have you ever been molested? Questions like that. Were you raised by a person who was depressed or who was, all of these different things? I mean, but it's interesting that only 20% of the American population has no ACEs. Most people have at least one. So it's fascinating. But the people that we're dealing with have a lot more than that. And so being aware of them is sort of the first step in trying to work through that, and trying to figure out this resiliency is kind of a big deal. Again, it's not one of those things people like to talk about, and so a lot of times what we do is we've got a parenting center over here at the corner of the clinic, and if you go outside the parenting center, there's one of our community gardens, and there's a lot of stuff going on around there. There's a workout facility and all of that, so people can show up there, and nobody's going to see your car in the parking lot and know why you're there. You could be there to go help, hoe vegetables, or you could be there for a lot of reasons. And that really, I think, helps our participation, is to not have it just that one thing. So anyway, that's what we do. Are we super successful? Well, I guess time will tell. I think part of it is honing into who your population is. I would not have guessed till we started studying this who our population was, but it's different than I thought it was going to be, at least for this deaths of despair that we have, because we're usually really looking at minority health and things like that. So it's kind of turned us on our ear a little bit. But anyway, thank you very much.